Hello everyone and welcome back to the class again. This time I'll be completing the last topics which were left behind, that is the ear and the skin. Regarding the answers of the applied importance of the eye that you have posted, I'm very happy to note that you have gone for searching the answers over the net and you have provided the answers also. You have given worked hard to provide the clippings also and to paste it into the PDF also. Well, that is highly appreciable and keep up the good work. You have come up with some new applied importance also, and that is of importance, such as which I have already mentioned in the class, like the presbyopia, like the blepharitis, the astigmatism, amblyopia. Well, these are the cases you will see in the ophthalmology also. Presbyopia is actually the kind of degrading of the lens which occurs because of age, and because of that your parents, and mostly after 40-45 people put on spectacles, no. So this is because of the stiffness of the eye, as you have already mentioned, and that is why the accommodation is not proper image being not formed over the retina sharpness. Okay, blepharitis is something in relation to stye and Calagian. You have written blepharitis, that is a full inflammation of the eyelid. You will see cases, of course. Astigmatism is something like which you see in case of when the cornea has got undulations. It is I have already told you that the actual dioptric power, I think maybe I have missed it, that the dioptric power, the power of the cornea is even more than the lens. 45 diopters is added by cornea and 12 diopters, 10 to 12 diopters is added by the lens. So actually the fine focusing is done by the lens and maximum focusing of the light is done by the cornea itself. So if the cornea has got undulations, then you will get distorted images. Okay, the distorted images of amblyopia you can search over the net and you can look how the person might be looking at the objects, how he might be finding things very much, some of the things in his vision, some of them are magnified and some of them are even smaller. Even he looks at a person's image, the person's face appears distorted. It happens. So this is important thing regarding the magnification through the cornea. Amblyopia and presbyopia, all these are the same things regarding the power of the eye. The ocular synechia, that is, yes, it has come to the light and it is very good also that you have brought to light. Actually, glaucoma, just like that, you will see certain persons after they have surgery, you will find that their iris is irregular. That is not glaucoma, okay? That is because after the surgery, that is a kind of not wanted or unwanted kind of thing which is occurring in the pupil. So that is the ocular synechia. And pinguicula you will find in your grandparents if you have above 80 or 85. The people, they have on the margins of the cornea a white lining. Okay, and also this one in your inner canthus of the eye, they have got a kind of tissue which is coming out. Okay, reddish kind of tissue, extra tissue. So that is pterygium. So all these things are brought to light. I am happy to know that you have gone through the internet search. And epiphora is actually the symptom, the not symptom, the sign. Like because of Deckard cystitis, the water, it is not drained and it is flooding out of the eyelids. That condition, it is called as epiphora. Okay. So I am happy to know that you have noted down all these things. So let us go through the slides of the year. Okay. So while going through the slides of the year, we have to open the PowerPoint. So the year, it has been divided into anatomically. into the outer ear, middle ear and the inner ear. See, in anatomy last class when I have gone through the clinical aspects more, then it becomes more meaningful rather than going through the words and the terms, right? So I'll just try to go as close as possible to the applied importance, but applied importance or the clinical aspect of the ear. But the thing is that the boring part, of course, I do also feel that the anatomy part cannot be left out, without being attended, because all of the diseases cannot be brought in the first year itself. Okay, so only the important or the most common diseases I'll discuss. So the ear has been divided into the outer ear. I have already told you outer ear, then the outer ear, the middle ear and the inner ear. What happens is, regarding the embryology part, I have told you already that the ear has been developed, the entire face has been developed from pharyngeal clefts, if you do remember. So the first pharyngeal cleft, the pharyngeal arches. So pharyngeal arches, they fuse in the midline and they form the face. Now the thing is that these pharyngeal arches are like form of fingers, like individual fingers. They are being stacked together one over the other, and they are coming in the middle and they are fusing. Now one thing is that between the fingers you see depressions, right? In the depressions, in the inside also you have depressions, and in the outside also you have depressions. The inside depressions are called as pouches and the outside depressions are called as clefts. Now what happens is, this ear between the first and the second arch, this is the first arch, this is the second, this is the third and this is the fourth. Four arches. Four arches, they come and they form the face. Okay, here they join in the middle. Now I have told you, inside you call it pouch, with the space between the arches you call it pouch, and outside you call it clefts. Okay, the inside pouches, each and every pouch has got importance. The first one, of course, it gives rise to a very important thing, and the cleft out of which the first one only is important. Here in this case every pouch is important, but in this case only the first one, the cleft. Cleft means bagheropra, the arches from the outside, the intervening area between the arches, that you call cleft, and inside you call it pouch. So pouch, first one, it gives rise to the Eustachian tube. You have a tube, right? Eustachian tube. You already know that from your previous studies, HS, that there is a tube which connects your middle ear to the inside of your pharynx. In fact, I have shown you also in the sagittal section that there is a Eustachian tube opening in the pharynx, in the nasopharynx. Napors onto part asilano, where you got the concha and the meatus. In the back side part, I have shown you that there is a opening of the Eustachian tube. Okay, so that opening is actually arising from this cleft, this pouch. Sorry. And from outside there is a cleft which is going inside, and this forms the external auditory meatus, or the opening for the ear. Okay, so the opening for the ear is from the first cleft, and inside you have the pouch. So this is the embryology part, that first cleft, first one of the cleft and first one of the pouch, they respectively go inside. One from the outside, this is the external auditory meatus, I am just abbreviating EAM, and one from the inside which is coming, this is the cleft which is invaginating, going inside, invaginating from outside. Okay, this is forming the external auditory meatus, so you have the ear outside. Okay, and in the inside of the nose, this is the nose, and in the inside of the nose you have got an opening. This is the Eustachian tube opening, Eustachian tube opening. Okay, what happens is both of them, they meet in the midline. Okay, when they meet in the midline, what happens is You give rise to a thin membrane. This is called as the tympanic membrane. So tympanic membrane is a derivative of all the three layers. As you already know that on the outside of the person you have got the ectoderm. Sorry, I will use a different color. Suppose what I use is for the ectoderm we always use a blue color since the screen is already blue. So I will use a green color. So this is the ectodermal layer. It has gone inside. Okay, and from the inside you have got the endodermal layer which is generally colored yellow. So this is the endodermal layer, and between them obviously there will be a mesoderm. Mesoderm is generally orange they pick up, so I'll just give an amber color. So this tympanic membrane has got the three layers. Okay, in case of lens I was telling it was derived from ectoderm, lens of the eye. Okay, here it has got all the three layers because one cleft from outside and one pouch from inside in the pharyngeal arches or branchial arches, when they fuse together then they give rise to this tympanic membrane. Okay, so now from this thing, this will help you to remember one thing, that the external canal is from the outside and the internal canal including the middle ear cavity, which I have termed here, no, middle ear. This is the middle ear. So the middle ear is built from actually the pouch only. Okay, and the inner ear, it is actually entire thing is apparatus which finally changes the sound energy into electrical energy, so that it is being transferred by the nerve, the special nerve, the eighth nerve. The eighth nerve is vestibulocochlear nerve. Two components: vestibular component for for equilibrium, and cochlear component for the cochlea, which is the inner ear, and that changes the electrical energy, the sound waves into electrical energy, and that reaches the brain in the designated area. Okay, so that is the eighth cranial nerve which is carrying the equilibrium and hearing both together. As of course the organs are separate, but the nerve it goes together. Both the nerves they are going together, entering into the pons. Okay. So now let's advance forward as to what are the things you are going to see in the external ear. Going to the next slide. So in the external ear, what you have to see is that the total length of the external auditory canal is a total of 24 mm. Okay, 24 millimeters, that is 2.4 centimeters, and out of this it has been divided into so out of this it has been divided into 6 centimeter which is cartilaginous, and 6 mm 6 millimeter which is cartilaginous, and 18 mm it is bony. So the outer part, when you enter inside the external auditory meatus, you have got the cartilaginous part, the entrance at the entrance, and when you go inside you have got the bony canal which is inside the special bone which is called as the temporal bone. I think you have seen the temporal bone. So this is the temporal bone, and here this is the bony part which is starting here. This is the external auditory meatus. Okay, so the external auditory meatus is the part which is made up of cartilaginous part. The cartilaginous part is there in a living body, but when you take out the specialized part, the temporal bone which is holding the whole of the ear, then it has the bony part, it is starting from the bone itself, and it is 18 millimeter in size. Okay, 1.8 centimeter. So this I want to show you that this is the temporal bone, and when I am holding it in an angle position, this is the zygomatic process. It is somewhere here, zygomatic process. This is the squamous part of the temporal bone. Okay, this is the mastoid part. It is somewhere behind your ears. You can feel a bony prominence here. Actually, the sternocleidomastoid muscle, it is attached in this part. The sternocleidomastoid muscle, it is attached to this bony part, and this conical projection which you are seeing, it goes to this conical projection. This conical projection, it is holding the entire ear, the middle ear and the inner ear, and some part of the external ear also. So which part of the external ear? The one which is the bony part. I have told you that 18 mm. So that 18 mm is being held in this part, okay, from this side. This is the lateral side I am showing of the temporal bone. So some part of this squamous part and some part of the mastoid, this one mastoid behind the ear, this makes up the opening of the external auditory meatus. Okay. Of course, you have got a pinna. Okay. So in the pinna, what happens is when you go for the the pinna part, then you have got one this kind of thing in which you have this opening of the external auditory meatus. Okay. Now what happens is you have got helix, the outermost lining. You have got a helix. Then you have got an antihelix. Okay. Please remember the terms. This is the helix. This is the antihelix. This is the tragus, and in the antihelix itself, in the lower part, you will get the antitragus. Okay, you have the helix, antihelix, tragus, and antitragus, and somewhere here you have got the cavity. This is called as the concha. Okay. And then this is the opening of the external auditory meatus, which is cartilaginous. Here, because since the ear is attached here, so you have got the the elastic cartilage of the ear lobule. Ear is there, so that is why you have got the cartilaginous part, and the downward part which is hanging down, it is called as the lobule. Okay. So these are the parts of the pinna, and this pinna in case of humans, it is not of much importance, because why, it is actually meant, it is a funnel shaped thing which is actually meant to collect the sound energy to be delivered to the external auditory meatus. If you have a certain direction of the sound energy you want to hear clearly, then you have to guide your external the ear apparatus, the external ear apparatus which is present here, okay, pinna, and you can hear it clearly, which is being followed in the lower animals, not in case of us. We can't move our ears. Of course, some of them, they somehow manipulate their faces and somehow they make their ear moves. But the muscles which are present here, they have become vermiform, and we cannot do such activities with our ear. Okay. So advancing forward, the pinna is the cartilaginous part of the ear. Okay, I have already told you. So pinna is meant to collect the sound energy, capture of the sound, and so that you have a voice which is louder. In fact, in case of dogs and the cats, you can see the cow also, they move their ear pinna so that they can hear clearly. In our case, it is not of much importance. Okay. Now, if you look at the structure in this diagram, then you can see that this is the external auditory meatus, which is coming from outside, and it is ending up into the tympanic membrane. So this is the tympanic membrane. The point which is important from clinical point of view is that the ear, the canal, the external auditory meatus canal, that canal is not straight as you are seeing in the diagram. Otherwise, if you had just taken a look into your canal, you can see the tympanic membrane. Just try to see it in your at somebody at your home. If you can see the tympanic membrane, no, it is not directly visible. In fact, if you are drowned or if you put your face directly in the water, suddenly a gush of water does not enter inside because of the, yes, of course it is a closed chamber, because of the air pressure it cannot directly go, but somehow if you manipulate also, it is saved, half of level of water and half of air. If somehow your external auditory canal is up till half of level of water and half in the air, then of course water can enter inside, and sometimes it enters also, but the approach is not so much direct. So in fact, even a foreign body cannot directly go much deeper inside, also inside the tunnel. So what is the schema of the tunnel? The schema of the tunnel is actually that it is from the external, from the pinna if I consider, then from the pinna I will see that the canal is advancing from the anterior aspect. From the external aspect it is advancing anteriorly, okay, and forwards and upwards, okay. So what the thing is that I have drawn it wrong. When it will come here, it will go forwards and upwards. So forwards thing I cannot show you in this two-dimensional diagram. I can just show that it is going medially. If I lay here, this is the tympanic membrane, I can show it is going medially, okay. I cannot show that it is going forwards, because forwards, if I have to show, that will be in the fourth dimension. So somehow I am trying to, you just keep it in your mind that it is going forwards. Forwards means towards the anterior aspect, it is going forwards, okay, forwards. Both the from the external auditory meatus, the opening, both the canals are going forwards, medially and upwards, okay. So I'll draw just the upwards part and forwards part, okay. Then it goes forwards and downwards and forwards, okay. Sorry, forwards and backwards. The second part is forward, of course, and backward, a little bit backward, okay. And then it turns downwards and medially. It is going like this. Try to make it out, okay. It is not a direct canal. Firstly, it is going to move forwards, okay, forwards and upwards and medially. Then it moves forwards and backwards and medially. Then it moves downwards and medially, okay. Then finally what you get is a S-shaped curve. It is like a S. From here you are approaching, it is somewhat like a S in including one more dimension, that is the fourth dimension. Just এটা dimensionৰ এনেকুৱা S নহয়, তললৈ গৈছেও ওপৰলৈও গৈছে. That is why when you have to hold and see the external audit, the tympanic membrane, when you see the ENT doctors, they are seeing, they are holding the pinna, they are moving it backwards and upwards, so that they can see the inside, they can move, they can as far as possible make it straight, the external auditory meatus, so that the tympanic membrane is visible. Yes, of course, we need a source of light, and you have to maneuver the pinna also, so that the external auditory meatus is straight. This thing in children is not developed. In the children, it is straight. Gradually when the adult form is achieved, then this S-shaped curve is attained. So what is the importance here? In case of a child who has been fed by mother, the breastfed, so the mother has to constantly take a notice that while feeding, after the feeding has been stopped, sometimes the child, they vomit out while they are sleeping. So that is why when after feeding, the child is being put into the shoulder and belching is done. They tap on the back of the shoulder of the child, so that he finally passes the gas from the air, passes the the air from the stomach, and then the food, it settles down. If he vomits, then he will vomit in, or he or she will vomit in the cloth, and if it is in excess, then it will enter the cavity and it will create some infection in the external auditory canal. So it has to be taken care of. Now going forwards in this slide, this canal, as I have told you, it is not a direct canal, direct channel which is straightforward. It has got a S-shaped curve, okay. And to maneuver that, you have to simply hold back your pinna upwards and backwards, okay. And then you can see the tympanic membrane, okay. You can peep in with the help of an external light source also. Now the thing is that in spite of having all these kinds of turns, there are certain foreign bodies which can enter inside, or because of the activity of the person, because of child, they are children, they don't know much, they are in a notion of picking up things and putting in the ear, some of them. So that may happen that the person might have foreign body lodged in that. So this is the applied part of importance. And also the skin of this external auditory meatus, they have got glands. So these glands are the sebaceous glands. What happens is the the same mechanism as you have infection, pimples developing over the skin, and the kinds of, when the pimples, when they are infected by bacteria, they may get enlarged. So such kind of thing, when it is developed inside the ear, since it is also skin, so you will develop a furuncle. So furuncle is a kind of development of infection of the skin sebaceous gland, and because of that, the it will be a painful thing, and the only thing you have to do here is prescribe some antibiotics, and then you have to give from outside, you have to give some kind of local antibiotics also, so as to remove that. Okay, so in maximum cases, when there is some problem in the external auditory canal and some foreign body is lodged, or some you have cerumen also, the earwax, that may also go and it may block this part. So earwax I am denoting by yellow color. Earwax will block the tympanic membrane, make it less mobile, so that you can't hear from the respective side of the ear. In that cases, simple, put a syringe and then syringing is done. So it is not the same syringe as you are giving the intramuscular or intravenous injections. That is a different kind of syringe which is used by any person. So this is, I am telling about the treatment part which they are doing. Okay. If you look at the tympanic membrane, then you will see that the tympanic membrane is a little bit angular. Okay, it is not a simple plane like this. It is a little bit angular, so that the anterior wall of the external auditory meatus and the inferior wall are longer than the posterior wall and the superior wall. Okay, that means the tympanic membrane is like this. Okay, this is the anterior wall and this is the posterior wall. Posterior superior part, anterior inferior part. It is a little bit oblique. So this is the direct, our sagittal plane. It is making an angle with the sagittal plane. Okay, so that this wall is longer than this wall. Suppose this is the external auditory meatus. So the distance between these two is longer than the distance between these two, right? So this is the thing which they want to tell. Now this tympanic membrane is lodged in the bony canal, and once you cross the tympanic membrane, you are inside the middle ear cavity. So let us go to the middle ear cavity. Middle ear, inside the middle ear cavity, you have got three bones which actually amplify the per square unit area incident sound energy in the form of waves to the movement of the ossicles. Why it is important? It is important to break the inertia of the fluid which is there inside the inner ear. Okay, I'll tell you subsequently. So to break that inertia, you need these movements of the ossicles, and these ossicles you already know: malleus, incus and stapes. So handle of malleus, it is attached to the tympanic membrane, and to the malleus, the handle of malleus, which is attached to the tympanic membrane, there is a muscle also which is coming and attaching to the handle of malleus, which is called as tensor tympani muscle. And after the malleus, there is the incus, and after the incus, there is another small ossicle which is called as the stapes. And to these stapes, there is a muscle which is coming from the back side and attaching to these stapes, and this is called as stapedius muscle. So you have the malleus which is attached to tympanic membrane, and so that's why the muscle is called as tensor tympani, and a muscle which is attached to stapes, and that is why it is called stapedius. The function of this muscle is, it is okay, they are amplifying, but suppose a large amount of energy, sound energy in the form of sound waves, suppose a fighter jet is going very near to you, kind of show, air show, and they are showing off that they are going at a very low altitude at the speed of sound, Mach 1, Mach 2. So when they cross Mach 1 and Mach 2, they will give rise to a exploding sound that is called like sonic boom. Okay, so that sonic boom, if it enters, it will destroy the entire thing in your ear. Okay, if it enters means it will obviously enter because the sound, the disturbance of the sound, that is the maximum thing I am telling. Okay, that is a maximum decibel velocity, decibel sound energy. So that energy, when it will enter inside the tympanic membrane, already there is an amplification device of ossicles, so that it does not happen when the disturbance is as a kind of reflex, when the disturbance is more than what is required, both of these muscles they become taut, so that the sound and excess sound energy is not being transferred by these ossicles. So this is a kind of protective device. The muscles are a protective device. Now in the middle ear cavity, you might be thinking that what is there to study, but the thing is the applied importance, from the applied importance part, the middle ear cavity is very important. Why? Because the middle ear cavity is a thing which is, which is closed space, and the only mode of communication is the eustachian tube. And if the eustachian tube is blocked, then this middle ear cavity might get infected, and since it is lined, since it is a living cavity, a living cavity is always having an epithelial lining, and the epithelial lining will secrete their substances because it is a living tissue. They will have their own secretions coming out, they will have their own, kinds of things they want to take in, food stuff, the individual cells, so they will imbibe in. So since these living cells have got secretions which are coming out, they will get inside the middle ear cavity, unable to be drained and unable to pass out, and that is why they may lead to immobilization of the tympanic membrane. So you have the conductive deafness. What is conductive deafness is actually when your sound energy is coming, unable to disturb the tympanic membrane, you are getting a kind of deafness which is called as conductive deafness. The other form of deafness is sensory neural deafness, when the nerve which is coming to the cochlea, that itself is damaged, or you have some problem in your pons also, maybe, because of which you cannot interpret the energy. So that kind of deafness is called as sensory neural deafness. Okay, it is a sensation which is carried by neurons. So the problem is there is in the neurons, problem may be there in the cochlear apparatus also. That deafness is sensory neural deafness. But the conductive deafness, this is happening in certain cases, now in this case by the middle ear. So if you look at the middle ear cavity, you will find that these are the ossicles. This is the malleus, handle of the malleus, this is the incus, and this is the stapes, footplate of stapes being attached to this part which is called as fenestra vestibuli. Okay, I will come across fenestra vestibuli. Again I will come across these terms. So look at this middle ear cavity which is ultimately draining into the eustachian tube. This is eustachian tube. Eustachian tube. So eustachian tube is opening into the pharynx. You already know. So what is the importance? What is the importance? Why not that some kind of you have the eustachian, you do not have the eustachian tube? What are the things which are going to happen? Yes, of course, this is lined by living epithelium. Thus there will be secretions which will be blocked. But is that the only thing for which the eustachian tube is important? Obviously not. What is the thing? The thing which is important here is that the eustachian, because of the eustachian tube, the air pressure which is there inside the middle ear cavity is the same as the air pressure which is there in the surroundings. Suppose you climb altitude, suppose you are going, suppose you take a flight, when you are gaining height, gaining altitude in a flight, your ear gets blocked because the eustachian tube, it is not open or patent all the time. While you are chewing, it gets open and gets again closed. It is not always open. It is not the kind of thing which is always like a drain, it is always open. No, it has got a kind of system because of which it opens and closes. But it maintains the air pressure of the middle ear equivalent to the atmospheric pressure. Okay. So while you are picking up altitude, your ear gets blocked. Even you have not taken to a flight. Suppose you are going to hide here in uh, while you are going to Shillong, while you are climbing the hills in Arunachal, you are taking altitude in Arunachal, going to some tourist place or some famous places which are at a height, then your ear gradually begins to block. Even if you are going for a sea dive, then also your ear gets blocked because the air pressure, suddenly there is a difference in the air pressure and your movement of the tympanic membrane is blocked. That is why you are supposed to chew the gum so that your pharyngeal muscles are acting, and because of the action of the pharyngeal muscles, the eustachian tube, they open and make it, make an equilibrium. Or you can do one more thing, you can just close your nose and mouth and try to blow out air. This is called as Valsalva maneuver, and by the help of Valsalva maneuver, what you do is you try to blow air into the eustachian tube to make the membrane, the tympanic membrane go free. Okay, so that the air pressure is equal. So Valsalva maneuver and the eustachian tube is in regard to the context that the atmospheric pressure of the middle ear has to be equal to the pressure in the middle ear has to be equal to the atmospheric pressure. Okay. Now there is something on the back side which is not shown in the diagram. I am taking a black ink. In the back side of the ossicles, I am drawing over the ossicles because I cannot remove the ossicles from the picture. There is a opening which is actually opening into this part. This is the mastoid process in which sternocleidomastoid muscle is attaching. This one here on the back side of the pinna. This process, since this is a bone of the cranium, we do not put over amount of ossification in any bones of the cranium, like God made it like that. In any bones of the cranium, you do not have areas in which it is consolidated like the compact bone. I am telling because in case of section that I have shown also in your class of bones, I told you that the long bones, when you cut it in a section, long section, okay, then you see that there is compactness on the walls. That compactness is never followed in the skull bones because it will make the skull heavy. So this is an extra amount of bone which is because of the projection, is because of the muscle, the sternocleidomastoid. Because of the constant action of the sternocleidomastoid, there is a projection. Since every muscle, when it is attaching, it will give rise to some kind of bony prominences, and in that part the bone is extra strong because there is a pull. So this bone is extra strong, but in spite of that, we try to God tried to make it light, and that is why there is porousness inside. This is called mastoid air cells. There is porousness inside. If I drill in, I'll get porousness, and this is the area in which you might have opening from, you might have infection from the middle ear. In the middle ear, of course, when there is infection, obviously there will be collection of pus here. Sometimes the same infection, it may enter inside, it will go on the back side, because you see this is the external auditory meatus. At the same level, if you consider that there is a middle ear, then on the back side this is the mastoid ear cells. So inside the middle ear, it is communicating with the middle ear. The mastoid ear cells, they are communicating with the middle ear with an opening which is called as aditus to the mastoid. Aditus means gate. So these mastoid air cells, since these are air cells or air sinuses, you have seen the frontal sinus, you have seen the maxillary sinus, you have seen the ethmoidal sinus. All of them have their openings, right? Opening থাকিবই লাগিব, because These are air cells which have got squamous lining. Our middle ears and opening lage to communicate with the pharynx. This air cell, these mastoid air cells also need a communication. Where will they communicate? In, this is the mastoid, and inside you have got the surface which is facing the brain. It cannot communicate with the brain. It has to communicate with the external environment to drain its contents. So what it does is it drains into the, it is having its communication through this middle ear and the eustachian tube to the pharynx. So you have got the frontal sinus which is communicating with the pharynx, right? The superior superior meatus, the middle meatus and the inferior meatus. Of course, it is only for the nasolacrimal duct. So superior middle meatus, since they have their openings of different sinuses, frontal sinus, ethmoidal sinus, sphenoidal sinus and the maxillary sinus, this mastoid sinus is also having an opening into the pharynx, but through the way of the middle ear, okay. And on the medial surface, this surface, as you can see, this surface, it is this. I was telling about the posterior surface of the middle ear. I have told you something about the eustachian tube, which is actually in the anterior surface, and this medial surface, it is directly facing the internal ear. So what I want to tell you is that while I am telling all these kinds of stories which you might be fed up, I want to directly pinpoint on the point that the middle ear has got a box inside, and that box is just like the room in which you are in right now. The room which you are in, consider that as the middle ear. So the things of the middle ear which you ought to know here is that what is there in the roof, what is there in the floor, what is there in the walls. So in a cube you have got 6 surfaces, 1, 2, 3, 4 surfaces, plus there is a roof 5 and there is a floor 6. Let us look at what are the things which are present inside the middle ear, inside the surfaces of the ear, middle ear. Okay. Middle ear, if you schematically draw, as a kind of cube, then what happens is, and from the anterior aspect, from this part, you have got the pharyngotympanic tube, which I have called as eustachian tube. So opening of the eustachian tube is there in the anterior part. Okay. Along with that, I have mentioned a muscle which is attached to the malleus. This is the tensor tympani muscle. So tympanic membrane is attached to malleus. So the extra disturbance of malleus has to be handled by a muscle which is attached to which has to be attached to the malleus. So malleus, tensor tympani is the muscle which is attached to the handle of the malleus. Okay. And this is coming to the middle ear with the help of another canal. Okay. This malleus tensor tympani muscle is coming from sphenoid. The sphenoid bone is just anterior to the temporal bone. This is the temporal bone of the left side. Just anterior to it, you will find the sphenoid bone. Just anterior. If you look at the base of the skull, you will understand. So sphenoid bone, from there, it is entering into this some few holes are there. From one of them, the tensor tympani muscle is going, and it is actually entering into the middle ear with to be attached to the handle of the malleus. So two things: eustachian tube and tensor tympani muscle. Two things. Okay. Now this upper part, this is the roof. When I have to describe about the roof, I am just actually going through this surface. See, this is the external auditory meatus. I will make it face laterally, since you have your ears laterally, not anteriorly, right? You have your eyes, not ears. So I will make it face laterally. Then what I see is, if this is the external auditory meatus, somewhere here I will have the inside. If I go, I will get the middle ear. So middle ear's roof is this one. This is the middle ear roof. So middle ear roof is nothing but the brain cavity itself. So what is lodged in this cavity is actually the, this part is actually the temporal lobe. Just above it you will get the temporal lobe. So the inferior surface of the temporal lobe is in fact lodged over the roof of the middle ear. এইখিনি জেগাত temporal lobe আছে ন? So temporal lobe is there, which is actually lodged related to the roof of the middle ear. I want to tell that thing only. Back side you have got the prominence here. I have already told you, and that prominence is called as mastoid process, and to this mastoid process the sternocleidomastoid muscle is attached, sternocleidomastoid muscle, and here you have got lots of ear cells. Okay, these are called as mastoid ear cells, mastoid ear cells, okay. So these mastoid ear cells are communicating with a gap or an opening which is called as aretus. Also, I have told you that there is another muscle which is controlling the extra sound disturbance and is attached to the stapes. What was that muscle? Stapedius. Stapedius muscle is coming out through a conical projection from back side to be attached to the handle of stapes, to the footplate of stapes, not handle. Okay. So this muscle which is attaching to the stapes, this muscle it is called as stapedius, and the eminence is called as pyramidal eminence. I will erase the ink on slide. You can see here this is called as the pyramidal eminence. Okay, so these two things, these are there in the back side. Also, very important is there is a nerve for the face which goes by the name itself, facial nerve. It is controlling every muscle which has to make you express. The muscles of the face which are there for your expressions, expression of your happiness, expression of your anger, expression of your sad mood, expression of your frightened mood. All those things are being controlled by motor nerve, motor part of the facial nerve, and that nerve is traveling from the back side of this posterior surface. It is very important, okay, so that it finally comes out from the inferior surface of this zygomatic arch. Here there is a facial nerve which is coming just below the external auditory meatus. There is an opening here. You can see there is an opening here. Okay, I think not much visible, right? But still there is a, just on the back side of the canal here below you have got the facial nerve which comes and directly it gives rise to branches. Facial nerve is responsible for controlling the muscles of your face, which are the muscles for facial expression. They are not meant to pull up a bucket of water. Do you pull up a bucket of water with your face? No. So they are meant for facial expression. So facial expression is carried, the innervation is by facial nerve, which is occupying the back side of the one of the surfaces of the middle ear cavity. Okay. When we go to the floor, we have got a bulge, because not a kind of bulge, but still very important structure, which is this structure. It is the internal jugular vein. It is the counterpart of the external carotid artery. The external carotid artery, whatever it is supplying, the venous supply is collected by the jugular vein, internal jugular vein. Okay, so the internal jugular vein, it is collecting the venous blood from there. Okay, and that is closely related to the floor of the middle ear cavity. If you look closely in this part, this is the temporal bone. Here just below, here you will get a fossa. Okay, so that is for the internal jugular vein. I know it is not much visible, but I am just trying to show you that although the things which are very big here I am showing, those are very small actually in the real sense. This is is a schematic diagram. এনেকুৱা ধৰণৰ বাকচৰ ভিতৰত সোমাই থকা নাই. It is a very small space. I am going to tell you further. So anterior I have told you, anterior surface, superior the roof I have told you, posterior surface told you, floor I have told you. The one which is left behind is the lateral surface. So lateral surface is the one which is facing the inner ear. From here, from this wall, if you break this wall, you will actually get the inner ear. Suppose this is the lateral wall, that is the external auditory meatus on that side. There is a tympanic membrane on there. From external auditory meatus to the middle ear, you have to cross the tympanic membrane. So tympanic membrane, from there, if you are approaching the cavity of this middle ear, which is actually this room, and the lateral wall, this wall I am meaning, the lateral wall is having the entire, if you break this wall, you will get the entire apparatus of the inner ear. Okay, so the inner ear is there present on the medial surface. I am sorry, I should have told you medial surface, because lateral surface is the eustachian tube. So on the medial surface, because you are coming to the midline, বাহিৰৰ পৰা ভিতৰলৈ আহি আছো, eustachian tube, external auditory meatus odi ahilo, we got the tympanic membrane. Tympanic membrane is the lateral surface of the middle ear. Aru bhitorle ahilo, dui side wall palu, hetu cross korile, we are going to get the inner ear. So the medial wall has got certain eminences. This is a bulge. The bulge is called as promontory. What is this promontory? The cochlear apparatus is just like a snail, no? You have already seen. So the cochlear apparatus, the basal turn of the cochlear apparatus, hamuktu jenpa enba agphale enba pokua thake no. So cochlea is like that, and that is why it is termed cochlea. Tar jonto sobot point to nohoy ekdom upor falor point to nohoy, tolor side to, it is very close to this, and it holds a bulge which is called as a promontory. And since the inner ear has to carry the sound, okay, it has to bring in the sound inside the cochlear apparatus to analyze it. The opening for that are two in number. One is called as, wait, I will be rubbing out this, and I will be rubbing out this also. Okay, so one of the openings, I will mark it in yellow. It is called as fenestra vestibuli, to which the foot plate of stapes is attached. And one is called as, this is called as fenestra cochleae. Okay, so what is the fenestra tympani. So what is there is, I was thinking about the cochlear apparatus, that is why it came to my mind. So that is called as fenestra tympani. What happens is, fenestra tympani is covered with a tympanic membrane itself, that is called as secondary tympanic membrane. Okay, we'll go into the details when we we'll try to understand the cochlear apparatus. For the time being, just I am telling you that the disturbance of the ossicles are being transferred from malleus to incus to stapes, and the foot plate of the stapes is attached to this part which is called as fenestra vestibuli, so that it transfers the energy to the vestibule, and that energy disturbance again is dissipated back in a turn, at a full turn loi ako hit kore over the fenestra tympani. Now the common words for the fenestra vestibuli and fenestra tympani is oval window for fenestra vestibuli and round window for fenestra tympani. Okay, so a disturbance to a full sucker mare inside the cochlear apparatus, and it hits back over the secondary tympanic membrane which is covering the round window, so that energy does not remain inside, it is dissipated. You hear one sound, it does not create a disturbance throughout your life. It has to go down, it has to fade, energy has entered, it is recorded, and then again it has to be sent back. Okay, so sent back to the environment. So middle ear kumale mane that the energy, the sound energy, again if at all lot of disturbance is there, it will be fading out to the eustachian tube, right? So because middle ear, that is why it is communicating with the outside with the help of eustachian tube. Okay, so what is important here is this presence of promontory in the medial wall. Presence of fenestra vestibuli, oval window, presence of fenestra tympani or the round window, and these are the things which are present in the medial wall. Okay, there is one more thing. There is a bulge of the semicircular canal which is also contained in the medial wall, but you can just remember all these things. And of course, the overall for that I'll be using the blue color, which is somewhat black also. The overall a gotte bostuto khuli thoisilo no, we have opened it to see this box, what it is covered with. Finally ki bostu khuli pelai we could see the box. What is this? This is the lateral wall. Yes, lateral wall, not the medial wall. This is the tympanic membrane. So moi jonto this misappropriate thing which I am telling, please try to reorient yourself. Ma ko editing no koru. That the thing is that you enter from the external auditory meatus, you go into the tympanic membrane. The tympanic membrane is there. You see the blue color tympanic membrane. You cannot go inside the middle ear cavity. Now what I do is I erase all ink on slide, and I see that you see that I have removed the tympanic membrane so that you can see the medial cavity. Okay, it has got a medial wall which is facing the inner ear, and that has got a round window and oval window, fenestra vestibuli, fenestra tympani. Okay, and the promontory, and also an impression of the semicircular canal. It has got an anterior wall which is carrying the your eustachian tube along with the tensor tympani muscle. It is coming here to be attached to the antennulum mammalis. On the back side wall you have all those air cells which is making the bone light, and there is an opening called as adductus of the mastoid. You have also got a muscle which is coming to attach to the stapedius muscle, and of course the muscle of facial expression that is coming close to the floor, very close to the floor. Okay, and then you have got the floor. In the floor you have got an important vein out there which is called as internal jugular vein. In the roof you have got the brain matter, which is the temporal lobe of the brain, and the plate which is there in the roof, that roof sabtu kiblipa, the roof, it is called as tegmentum tympani. It is a thin plate of bone. There are problems, middle ear cavity যদি infection হয়, or if it is the infection, it is going in the roof and it is eroding the bone, you might get infection into the brain also. Very important organ it is. The infection can't be left unattended. Yet kiba eta boil hoise, you have got cellulitis here, you may leave it for some time to at least see that it is subsiding or not. No, not in this case. One thing is that once you become symptomatic, it has already gone into a much greater extent. The second thing, if you wait, then it will start eroding the bones. And also, if the infection goes to the back side, there also the mastoid air cells are communicating. Actually, this is the mastoid process. On the inside you are seeing this is actually the surface of the brain, especially the posterior part, the cerebellum and the cerebrum, posterior parts of the cerebrum. Here also you can't leave unattended, otherwise it will affect the brain. Okay, so since it is in close proximity with the brain, so that is why this structure of this particular part is very important. So let us advance forward, not remain here. The inner ear we have to go through. The inner ear is actually having an apparatus called as a cochlea, and the entire thing is approximately lodged in an 1.8 millimeter area. Okay, 1.8 millimeter in length total, and in that area only you have got the cochlea, and the continuation of the cochlea on the back side, okay, is called utricle and saccule, and it has got 3 rings over that, just like the peacock trying to show off its feather. Consider that the peacock is the body of the peacock is a cochlear apparatus, and it has got a utricle and saccule towards the posterior part of the body, and the feeder which it is showing off, it has got 3 canals, and those 3 canals are posterior, lateral and superior semicircular canals. the thing which you have to understand here is, in the inner ear, what we see is, in the inner ear, this apparatus, it is called as the cochlea. The cochlea is like the snail, and this part, the turns is only 2 3 by 4 turns. It is not 3 তিনটা টার্ন ফুল নলয়, দুটা টার্ন লয়, প্লাস এটা টার্ন যোনটোৰ 4 ভাগ কৰিলে 3/4 it is come taking and 1/4 is still left. So 2 3 by 4 turns is the turn of the cochlea. Okay. Now in the cochlear apparatus, what you have is, you have got a central part which is called bony part, which is like a spike, and it is called as the modiolus. What it is carrying? It is carrying the vestibulocochlear nerve. I will take the yellow color for that nerve. So see the thickness of the nerve. Just compare the structures. Structural comparison to Swaya, that the nerve is, as compared, you will get a nerve which will be entering here and comparable to this foramen. Epalliye enter kore, A2 foramen enter kore. Okay, and in this foramen, the cochlear apparatus, see the size of the cochlear apparatus. It is somehow accommodated at the tip of the, the nerve, very small thing. And on the back side of the cochlea, you have got the utricle and the saccule. I will use a different color. You have got the utricle and the saccule, and on the back of it you have the superior, posterior and the lateral semicircular canals. So this is the entire thing of the inner ear. Okay, and this is actually, when this is which side, you have to know the side also. I am actually describing the side in which this part, it is occupying a bulge in the middle ear. This is called as the promontory. I have already told you. The basal turn of the cochlea is giving a bulge over the middle ear. Which surface of the middle ear? Medial surface of the middle ear, because middle ear cross korihe bitorle medially aru bitorle aru majole ahile, that you will get the cochlea. So the basal turn is hitting or making a prominence out there. Okay. Now if I make this cochlea a straight one, suppose I make this cochlea a straight one, what will I get is, I will get a membranous structure inside, which is called as membranous labyrinth. And it is the water which is there, the fluid which is there, it is called as the endolymph. Okay. Do not go into much detail, just remember that this is endolymph. And the fluid which is present on the outside of the membrane, there is a fluid of course which is present, and this fluid which is present on the outside, this is called as the perilymph. Both of them are communicating. Okay, so this is called as perilymph. Perilymph, in short, you can say that perilymph is actually not a kind of secretion from the cells. It is actually a CSF continuation only, but endolymph is a kind of filtration. It is not directly the content of CSF. Okay, but perilymph is somewhat, the constituent is some similar to CSF. So CSF to seep in kore to make the perilymph. So not going much into the detail. What I am interested in is, I want to tell you that, I missed the diagram. So once again I will draw it. So this is the inner ear. This is the inside part, which is the membranous part, and what I have drawn here, it is the perilymph, and this is the endolymph. Now what is present here? What is this and what is this? I am interested in. This is nothing but the oval window, and this is nothing but the round window. So what is there in oval window or fenestra vestibuli? This is called, what is attached here? Yes, this is stapes. And what is there in the round window or fenestra tympani? This is the secondary tympanic membrane. Now what happens is, when the disturbance is traveling in this direction, it travels back and hits back at the secondary tympanic membrane. So the disturbance, once it creates the disturbance, it is also lost once it has been recorded. How it is recorded? The disturbance, it creates a kind of simple harmonic motion inside the membranous labyrinth. You have already studied the SHM, simple harmonic motion. So what is there inside is, inside these cells, inside the membranous labyrinth, you have got certain important hair cells which are having stereocilia. Here report কিছুমান hair cells thakas, there are cells, and this disturbance is being recorded by these cells, which are the inner hair cells and outer hair cells of the cochlea. And these hair cells, the disturbance is being changed into what? Yes, the disturbance is changed into electrical energy, and that is finally passing through the, yes, through the cochlear nerve. So once again I am telling you, this is nothing but the cochlear apparatus being made straight. So what I have done is, I have cochlear apparatus made straight. Sidha kori disu, hamukor jontu pak asle no, I have made it straight to make this diagram. It makes up about 35 mm when it is made straight. নহলে কিমান সৰু জেগাতে already all the things are there. Cochlea is there, utricle saccule, semicircular canal, গোটেইখিনি 18 mm মতে সামৰি যায়. But to make the cochlear apparatus straight, you make it up to 35 mm, and that is being turned into, you make turns of this to finally make 2 3/4 turns of this apparatus, which is called as cochlea, and this is the modulus. Okay, and on the back side of the cochlea you have got the utricle and saccule plus saccule, and on their posterior parts you have got 3 rings. These are called as semicircular canal. So this is the entire thing. Okay, so now let us advance to the slides. So this is the bony labyrinth which I have described, the entire utricle saccule. Inside the bony labyrinth you have got a membranous labyrinth. Membranous labyrinth in the cochlea, it is having the sensitive hair cells which are recording the vibrations in the lymph, in the membranous and in the endolymph, and they are changing it into electrical energy. The same membranous endolymph which is there inside a membranous layer, it is being continuing in the utricle and saccule also, and inside the semicircular canals also. But in the semicircular canals, the thing which is, this is the apparatus, see, which I have described, and inside the semicircular canals, this the same diagram which I have drawn. The recording device is actually otolith. There are some kind of granules which are present there. These are called as otolith. So these granules, which are called as otolith, either in the utricle or in the saccule or in the semicircular canals, when you are moving your head either anteriorly, posterior or towards the sides, these otoliths, they are also disturbed because of the gravity. Okay, so because of the gravity, when they are disturbed, these hair cells, they are recording the disturbance and they are sending it to the brain with the help of which nerve? Not the cochlear nerve. This time it is the vestibular nerve. So utricle plus saccule, they are sensing the disturbance of linear acceleration. Please remember that you are moving in a very speeding car or you are moving fast is being sensed by the utricle and saccule. But when you are holding hands of each other and making a merry-go-round, okay, moving very fast in a circular manner, that is being sensed by semicircular canal. Semicircular canal, they are sensing the rotation. Okay, so the round and round rotation is sensed by the same thing with the presence of otoliths only and with the help of the vestibular nerve, but the sensors for the rotational form is there in the semicircular canal and the linear acceleration is present in the utricle and saccule. Okay, so these are the things which are to be kept into mind in the inner ear. So as I have already told you, all these slides, the same thing is uh, being spelled out here. So with this, I complete the external ear, the middle ear, and the inner ear. Of course, the applied importance is important. So in the applied importance of the middle ear, the middle ear applied importance is first thing, there is the presence of infection and collection of fluid which is called as otitis media. Now this otitis media, it may be either acute, they are measuring it as acute or chronic in the form of some weeks, okay, so like 6 weeks and all, I forgot even the pinpoint. In ENT part when you will be going, you will be studying about all these things. So when the same infection is being carried and the person is having that infection without pain carried on, this is called as chronic. So it has got two divisions, acute otitis media and chronic otitis media. When the infection is coming from outside, maybe traveling from the pharynx also, okay, because you have got the eustachian tube which is continuing there. What happens is this fluid and the bacteria which is growing in the middle ear cavity, this may perforate the tympanic membrane. So tympanic membrane rupture is a complication in addition to the bony erosions which will lead to infection to the brain. Infection to brain. Okay. So these are the complications which may happen because of the infection in the middle ear. And the inner ear, the problems which may arise is one, it may give rise to sensory neural deafness. You have some persons in which the nerve got damaged because of idiopathic reasons also, maximally it happens. Bohutor ase enekwa, suddenly there is a loss of hearing. And they found that the tympanic membrane is okay, the ossicles are okay, no problem in the middle ear. Finally they got the sense that the nerve has been damaged, the cochlear nerve. And also, if the vestibular nerve has got disturbances, these are most common. There are a lot of diseases. Because of this, there is a specialized branch only, the ENT branch, which is dealing with the middle ear, which is dealing with the ear. But some of the named things which are very common, that only applied importance I am telling. So vestibular nerve, when it is damaged, so what happens is the person is suddenly he will have loss in the equilibrium and balance. Okay, it is not about the alcoholic that I am telling. Alcoholics have that problem is because the cerebellum, which is the center of analyzing the balance, that is gradually it is deteriorating because of the alcohol. But vestibular nerve, when it is damaged, I have seen in my childhood that I saw a person which is uh, in my village, I saw a person who was lying down in the bed. Suddenly, she'll catch hold of the bed, and or otherwise the person who is next to her, very close to her bed, and she'll say that I'm falling down. I'm falling down. So this kind of the things that are rotating in the vision, kind of things, the feelings that are coming is because there is a disturbance in the vestibular apparatus that may happen. Okay, there are diseases implicated to that. So you can go through if you want to. With this, I complete this here part. But I have one more thing which I'll be discussing along with this. So we'll be discussing the skin. So just I'll finish off the skin part, which is the last part. I'll be finishing off here most of the things, except that if you have doubt, you can discuss. So the skin anatomy, basically skin is the largest organ. See, skin is there which is covering the whole of the surface area. That is why even if we consider we will be in a notion like the liver is so large, but this organ it is spread throughout the surface of the body. It is the largest organ. So the skin is very important. The point that the dermatologist section, the study about the diseases of this part is gaining importance, because skin diseases as such, there are serious diseases, maximally autoimmune. These are when your own body senses some particular parts of your body as foreign, then you have a disease which is called as autoimmunity. Maximum skin diseases which are lethal are actually related to skin autoimmunity. Okay, so autoimmunity is closely related. The manifestations of some other forms of autoimmunity also goes to the skin. Okay, so in that part, and also the cosmetic dermatology, which is related to the well-being of your skin and your beauty, that is gaining importance. So what you have to study in anatomy is not that the skin is related to anterior, posterior, lateral, medial, nothing like this. Skin, you have to just know the histological layers. Before that, I must have to tell you that the skin has got an epidermis, it has got a dermis. The color that you have, and when you have a slight amount of injury, when you see a white thing coming out, suppose you have a bruise, you got because of an injury, the color of your skin suddenly you have kind of injury in which the color of that particular injury area without bleeding, you got a white color. That means you are landing up in the dermis. So you can very well think of how thin is the epidermis, and this epidermis is an ectodermal layer derivative. I have discussed with you the three germ layers, the ectoderm, mesoderm and endoderm. So the ectodermal layer is this epidermis, and the rest, the dermis, hypodermis, these are actually derivatives from the mesoderm. Okay, I think you can remember this much. Okay, moving on to the next slide. The next slide, I want to directly go into the layers. So the layers of as I have told you, the broad layers are firstly the epidermis, then the dermis, and below the dermis you have the hypodermis. Okay. The epidermis has been divided into the following layers. The outer layer, which is comprising of the secretion of these cells of the skin. The living cells are there in the lowermost layer. Gradually, when they are moving up, actually the same layer of cells, they are moving up and they are forming the surface. I am discussing about epidermis, not the dermis. About the thin layer, when you got a minor amount of abrasion or a minor amount of injury to your skin, suddenly you saw there is no bleeding, but you saw a white thing coming out. That is because the epidermis has been eroded off. Only slight white amount of thing, that is dermis, is visible with small micro spots of bleed. Micro. Okay, small red tinges you will see. So that means the epidermis is eroded off. So epidermis, such a thin layer, that itself has got so many layers. The lowermost layer is living, and the uppermost layer, when it goes towards maturity, it becomes non-living. And the thing which is finally left out is its secretion. and the secretion is called keratin. In fact, keratin is making up your nails and also your hair. This is the same epidermis which is having a separate kind of secretion, or they are arranged in a different form together, not in this kind of parallel layers of strata. এনেকে এটাৰ ওপৰত এটাকে নহয়, they make whorls, এনেকুৱা গোল কুঁৱাৰ নিচিনাকে চাৰিওফালে হয়, they make up the hair follicle. Same secretions in the nails also, a separate kind of arrangement of these layers only, they make up the nail bed and they make up the growing nail. Okay, so this uppermost layer is called as the stratum corneum, where the cells are dead, mostly they are dead. This is the dead cell layer. The downward layer, where you have got dead cells only, but they have got somewhat lesser secretion than the stratum corneum, this is called as stratum granulosum. These two layers are thin, but the thickest layer is the stratum spinosum, where you see the large cells in the downward part, and gradually when they are going upwards, they are somewhat becoming flat. Okay? This is a living layer. From here below, where when I am going downwards, you will get living cells, but this stratum spinosum, which is the thickest, it is the thickest of all the layers of the skin, these cells are living and they are secreting actively keratin, and they are moving and going towards the upward side to make up the stratum corneum. This is a progression from downwards to upwards. Okay. Stratum basale and the term stratum basale is the lowermost layer, in which this is the mother of all the cells which are derived from which are found above. You have got the spinosum, granulosum, corneum. The mother cell is there in the stratum basale. They are continuously dividing cells, living cells. They are not having any kinds of all those corneal keratin secretion, and when these cells mature and move up, they go through spinosum, they go through granulosum, they go through lucidum, there is one more layer, lucidum, and then finally stratum corneum. তোমালোকে ইমানখিনি মনত ৰাখিলে হ'ব, all these layers. Okay, and in this you are going to get specialized macrophage cells which are called as Langerhans cells. Macrophages in the blood, no, the same resident macrophages যোনবিলাক এটা থাকি গ'ল, এটা ঘৰ বনালে, these are called as Langerhans cells. And you have got specialized cells which are making up your color, these are called as melanocytes, which are present in the downward part, the basal part. And also the marcal disc, these are pain sensory organs which are present in the epidermis. Yes, of course, you have got few more other things which are important, such as the Meissner's corpuscle. These are sensory nerve endings, Meissner's corpuscle. Pacinian corpuscle, which is sensing pressure. So these are special kinds of nerve endings and free nerve endings. Free nerve endings, they sense pain. So these are kind of modification of the nerve, so that you get different kinds of reception over the skin. I place a tuning fork over your skin, you can sense the vibration because of all these different kinds of modification. Just you need to know the names. Pacinian corpuscle, Meissner's corpuscle, Marcus disc, free nerve endings. Free nerve endings, I pinch here, oh, so that is the free nerve endings. The pain sensation is to the free nerve endings. Okay. Coming back to the slide, this is the these are the different layers that they have described: stratum granulosum, stratum spinosum, and this is the granulosum. Finally, the stratum lucidum. I have told you there is one more layer. Okay. In the dermis part, you have got the papillary and the reticular layer. Let me tell you one importance of this layer is that your fingerprints, the ridges that you are finding, that is because of the reti ridges which are found in the reticular layer of the dermis. So the reti ridges, they are making the undulations in your skin to make up a fingerprint of yours. Okay. So the associated structures which are found in this skin is actually the sebaceous glands and the sweat glands. And also nail and the hair I have already explained. Nail and hair are not just like skin flat, because the arrangement of the cells of the epidermis, they form, suppose in case of hair, they form follicle. Follicle is nothing but they are arranged in a circular fashion in and attain a tubular manner, just like well, no? কুঁৱাত যেনেকৈ বস্তুটো you have got wells which are neatly maintained. You got a ring, a cement ring. So consider that cement ring is actually a layer of epidermis which is constantly secreting cornea, stratum corneum, and that stratum corneum is actually growing out of a tubular projection which is the hair follicle. And a little bit of modification in the secretion, they make up the nail. Okay, nail and hair done. Sebaceous and the sweat glands, these are actually pores from the epidermis which are containing the layers of the epidermis on the linings. Here the epidermis stratum corneum layer will be on the topmost. Okay, and in this you have got sweat glands and also sebaceous glands which will be throwing out their secretion, oily secretion and water. Okay, through the hair follicle. This is the hair follicle. Sorry, I didn't draw the hair like that. Through this hair follicle, at the root of the hair follicle, you will get the sebaceous and the sweat gland secretions being thrown, and they are coming out through the pores. So that finally, if you do not take bath, okay, very nicely, or somehow because of some other reason, due to excessive secretion of these sebaceous glands also, there may be infection here. So because of the infection, there may be infection here, and because of the infection you will see redness and swelling on the skin. You have got pimples. So the first thing they will advise you is wash your face regularly, so that the excess oil is being washed away. If you have got too much of infection because of bacteria, then they will advise you pills, the antibiotic pills, especially meant for this infection. Okay, and then finally there is no other solution, that you have so much of excessive secretion, then they give some other kinds of medicines which are not advised during pregnancy. So these are cosmetic things which are important and dealt with from a branch of this medical science which is called as dermatology. Okay, so let us go through the diagram. This is the sweat gland which is present here, tubular form, and there are presence of sebaceous glands out here. It is not drawn here. So sebaceous gland, you can see here that this is a epidermis running. It is not that the sebaceous gland is not there in the epidermis. The lining is continued down around the hair follicle. So it is in the diagram, in directly layer-wise diagram, you may think that this is epidermis and this is dermis. So you might think that hair follicle is arising from the dermis, but no. There is a lining of the epidermis. I will use a fluorescent color. The lining of the epidermis, it continues up till the dermis. So you can't say that it is there in the dermis. It is in the epidermis only, because the layer has continued down. It has invaginated into the dermis, but it is the epidermis only. Okay. So one more thing I want to tell you, that the sweat glands, the modification of the sweat glands, one type of modification of the sweat glands is found in the entire mammalia kingdom. And what is that? That is the breast is actually a modification of this gland only. So from the duckbill platypus, if you search over the internet, the duckbill platypus does not have an organized form of this mammary gland, the breast, and their secretion, they are coming out through the hair follicle. So from that, it becomes a direct link that the sebaceous gland is so much important that in the mammalian kingdom, the breast has been entirely developed from the sweat gland. Okay, so this is from the evolution point of view, I am just telling. The embryology, I have already told you that the ectoderm, it is directly making of the epidermis, and the mesoderm, they are making of the rest of it. On the applied part, you have got, the acne I have already told you because of the infections. Then the albinism and vitiligo, these are the, disturbances related to the melanocytes. So when you have got the melanocytes being killed, maximum I have told you that in case of the skin diseases, maximum it is kind of form of autoimmunity or auto destruction. So the melanocytes, when they are disturbed, they will either make the whole person go, white color albinism, or in patches vitiligo. Okay. And the skin disorders maximally found which is dangerous is the skin cancer. You will also find some persons which are having flakes of skin coming out, commonly found disorder, flakes of skin, shiny white, মাছৰ যেনেকুৱা বাকলি থাকে ন, shiny white, like that. The person doesn't have pain. Patchy areas or the whole of the flexor or extensor aspect, এই গোটেইখিনি extensor aspect এনেকুৱা বগা হৈ থাকিব, flakes like, you will feel like he is not taking bath properly, but no, the person is very, tidy, but in spite of that he has skin flakes coming out. That is a form of disease which is called as psoriasis, commonly found disease, psoriasis. This is because of excessive turnover of the layers. The basal layer, it changes into spinosum, then to granulosum, then to corneum. It takes some time, 45 days. When the turnover time is decreased, then excessive scaling will be produced. When you take out the scales of that person, you will be seeing small bleeding points. That is nothing but the person is extremely well, but still there is a kind of depression which is built in. So maximum skin diseases are not creating as such any trouble, but they are creating some psychiatric problems. That is why skin diseases have to be dealt with, they can't be left behind. Okay. So with this I complete the topic. Thank you for watching.